Thank you very much to the organizers for inviting me and for being here and talking about another age group, I think, one that has been less discussed today, older adults. I want to disclose the following financial relationships. Yes, as was said during the introduction, we have a clinical vaccine evaluation center, so we collaborate with many companies, but I'm not personally paid for that. All payments are done to my institutions, and a specific mention I want to make is the fact that I'm a PI of one of the clinical trial sites of the RSV GSK study, which is going to be discussed during this presentation. But I have obviously remained neutral in discussing the different trials. So the content of my talk is to reflect a little bit on RSV infection and the burden of disease in older adults, an overview of RSV development, but that was excellently shown in the previous talk, so I will be very brief on that and focus on the older adult studies, to then dig into somewhat more detail into the three main, or let's say most advanced candidate vaccines. In the meanwhile, one has already been licensed. And then, yes, some reflections, and you will also notice that the reflections I will make, there are also quite some similarities with the previous talk. Well, first of all, as you all know, we get infected with RSV several times throughout our lives, so immunity is long-lived. Is not long-lived, is short-lived, and age is a major determinant. So we've all known and we've talked about it today, the fact that young children are at high increased risk for RSV and all its consequences. But during the past few years, there is increased awareness of the fact that the burden of disease in older adults is also quite severe and has been underestimated for many years, also due to the fact that we have little surveillance data available. The clinical picture of older adults is often an insidious respiratory illness, which can last for a much longer period than in younger adults. It can lead to exacerbation of underlying disease, such as asthma, COPD, but also chronic heart failure. And as you can see here, this is due, or at least can be partially explained by differences in the immune response of the older adult, the fact that immunosenescence is present in mainly frail older individuals. So there is the innate immune response becomes activated in a less pronounced way. The T-cell response is certainly decreased. That has also an influence on the fact that the viral clearance is lower, and the viral load, the viral shedding, will be longer and higher as compared to a younger adult. So these are all phenomena which have been described. The antibody response as such, the neutralizing antibody response, is not that much different, and that is also something we have seen in the trials. Indeed, a definitive correlate of protection remains elusive, but we do know that neutralizing antibodies combined with CMI, cell-mediated immunity, and preferentially also mucosal IgA have been associated with protection. Well, to give you some figures on RSV burden of disease, I have selected one meta-analysis which has, made an evaluation of the literature, the qualitative literature of the past approximately 20 years, between 2000 and 2019, and they came up, or they selected only 14 papers with PCR data, but also seroconversion rates. They have used these estimates on attack rate, hospitalization. I'm sorry, this is the pointer, or it's not working. They have used these estimates on attack rate, hospitalization rate, and in-hospital case fatality rate, they have extrapolated that to the 60-plus population in 2019 to come up with these estimates on the upper panel in high-income countries and the lower panel specifically for Europe. So an estimated 3 million cases of acute respiratory infection, 273,000 hospitalizations, and about 20,000 in-hospital deaths. But we do not know about out-hospital deaths. Data on RSV burden of disease in older adults in low and middle income countries are even more scarce. So to, summarize this, risk factors for severe infection are older age, being immunocompromised, chronic heart and lung disease, and diabetes. And on the other hand, the complications you can expect of RSV in older adults are lower respiratory tract infection, exacerbation of these underlying diseases, hospitalizations, and in-hospital deaths. So these are, of course, important objectives, endpoints to be monitored in clinical trials. I don't think I need to repeat this message, but the important breakthrough a little bit more than 10 years ago indeed has been the fact that we were able to, I didn't touch it, and yeah. Okay, thank you very much. Yes, the fact that we have been able to stabilize the fusion protein, the pre-fusion conformation, to have these important epitopes indeed very visible to our immune system. So this is a major breakthrough. I was not aware that, Jonne, that you are one of the co-authors of this amazing review, so very grateful for that. This is indeed a picture you have already seen in the previous presentation, showing the various strategies that are being explored for the development of an RSV vaccine. And I am going to focus on the phase 3 vaccine candidates in older adults. You can see here that there are 5 vaccine candidates. 2 are protein-based subunit vaccines, pre-F and pre-F3. Then there's 2 vector-based vaccines, the adenoviral vector vaccine and the MVA, modified Vaccinia Ankara from Bavarian Nordic. And then the 5th one is an mRNA vaccine from Moderna. The name of the molecule is mRNA 1345. I could already, because it is a rapidly changing landscape, we can already omit one, because Janssen very recently, Johnson & Johnson, had a press release declaring that they are going to halt the development of their candidate RSV vaccine for older adults. Although I have to say the phase 2 results were certainly not bad. The vaccine efficacy was around 80%. They were quite vague, but it had to do with a reorientation of the portfolio. I think the fact also that adenoviral vector vaccines, because of the experience with COVID, don't have the best reputation. So maybe a combination of these elements has led to this decision. So the Bavarian Nordic, I need to add, Bavarian Nordic phase 3 study is ongoing and they have not published any results yet. So this could not be included in this overview. So I have focused on the following 3 vaccines. It is certainly not my purpose to put them in this kind of table for the efficacy results, because you cannot compare these efficacy results side by side, as these are different clinical trials. But I did want to put them in a table as for what are the vaccine characteristics, where are the similarities and the differences. So RSV pre-F3 is the name of the GSK vaccine candidate, referring to the trimeric fusion protein. Pre-F, very similar, is the vaccine candidate from Pfizer. mRNA 1345 is the Moderna vaccine. The first 2, as I said, are pre-fusion protein vaccines, so it's really the soluble trimeric protein being present in the vaccine at a dose of 120 microgram. The GSK vaccine is based on the RSV-A strain, so it's not a bivalent vaccine. The Pfizer one is 2 times 60 microgram of RSV-A and RSV-B. Moderna, obviously being an mRNA vaccine, it contains 120 microgram of mRNA which encodes after injection or which codes for the RSV prefusion protein. All 3 vaccines have to be administered as an intramuscular injection and a single dose. Giving multiple doses in a priming schedule has no added value. All of these individuals have pre-existing immunity that has been explored in the phase 1 and 2 trials. Other relevant or important components to mention is the fact that the GSK vaccine has an adjuvant contained in it. It's a liposome-based emulsion with MPL, monophosphoryl A, which is a toll-like receptor 4 agonist, and QS21. The Pfizer vaccine contains no adjuvant, and the mRNA vaccine is encapsulated in lipid nanoparticles, which also has, which of course takes care of the delivery, but also has adjuvant activities. The names of the clinical trials are depicted here. They're all phase 3 randomized controlled, placebo-controlled trials, and all of these studies are still ongoing. Results of the first 2 have been published in New England Journal of Medicine very recently, and for the Conquer RSV study, I took, results from a press release which Moderna has released a couple of weeks ago. The sizes of the studies is a bit different, 25,000 in the GSK trial, 37 in the 2 other trials, and the age range is the same. Well, before we move on, so I'm going to show you the results in that order, but for the GSK study, I wanted to show you just one slide on the study which preceded the phase 3 study, just to show you how they selected the antigen dose and how they made the decision to include an adjuvant. And also because, well, this is a study which we participated, so we know this trial very well. So it was a study in more or less 1,000, a smaller group of young adults and 1,000 older adults, with in total 9 groups, as you can see on the left-hand slide. So they evaluated the antigen, the prefusion protein, in 3 antigen dose levels, 30, 60, and 120 microgram, without an adjuvant, with the AS01B adjuvant, so that's the one on the right-hand side. As a reference, it's the same adjuvant contained in the shingles vaccine, Shingrix, and AS01E, the middle bar, is actually half a dose of the AS01B. So on the left-hand side, you can see the fold increase, the titer increase of antibodies, neutralizing antibodies post versus 1 month post versus pre-vaccination. So you can clearly see an effect of the antigen dose level with the 120 microgram leading to fold increases of 9 to 10. And there you saw that actually the difference between the non-adjuvanted and the adjuvanted vaccine was not clear if you look at neutralizing antibody levels. On the right-hand side, you see the T-cell response. On the bottom, you see the pre-vaccination levels, the baseline values, which were similar in all 3 groups. And then post-vaccination, you see a clear effect of adding an adjuvant as compared to the non-adjuvanted vaccine. You could say, well, AS01B gave an even better value, but eventually the choice was made to include the lower dose because that gave the optimum balance between immunogenicity and safety. Okay, so let's look at the phase 3 study. It took place in 17 countries, spread across the world, so Africa, Asia, Australia, Europe, and North America. Persons with stable chronic medical conditions were eligible, immunocompromised persons were not. So the primary objective was vaccine efficacy against RSV-related lower respiratory tract disease, and they had a variety of secondary objectives against the less severe ALRI, acute respiratory infection, against severe lower respiratory tract disease, so necessitating hospitalization, mechanical ventilation, or supplementary oxygen, and then also a variety of subgroup analysis to see if the vaccine was also efficacious against subtype A and B according to age, coexisting conditions, frailty status, and so on. For your information, because there is some slight differences in the definitions in objectives and endpoints between the studies. So an LRTD was considered when at least two lower respiratory signs or symptoms were present, or at least one sign, and you see the signs and symptoms in the lowest box, or at least 3 lower respiratory symptoms, obviously in combination with a positive RSV PCR. The results, demographic characteristics were balanced between the study groups. Median age or mean age around 70. 1/3 was in their 70s and 8% was above 80. A nice gender balance. Majority were white, so almost 80%. And then frailty status, very low number of frail older adults, but 38% were pre-frail. A gait speed test was used to evaluate that, and almost 40% had at least one pre-existing condition. So the outcome or the result of this primary objective, over a period of 7 months, or 6.9 months to be precise, which is indeed longer than an average RSV season, 7 of these events occurred in the vaccine group versus 40 events in the placebo group, accounting for a vaccine efficacy of 82.6%. The lower limit of the confidence interval was 57.9, and in the protocol they said it had to be above 20 to have a successful study and a significant study. So this criterion was clearly met. Some more results. I'm aware this is a busy slide. The cumulative incidence curve. They started counting the cases from day 15 onwards after vaccination. That's what you see on the left-hand side. And on the right-hand side, I just want to, give you an idea of all these point estimates on vaccine efficacy for the secondary subgroup analysis. So you get very robust results, high vaccine efficacies, with the exception of the group above 80. There, of course, it's due to, you have very wide confidence intervals due to the fact that it was a very small group. The same for the frail older adults. The groups were too small to give any, to have any statistical significant result. But there's no reason to expect that it should be lower, because the you don't see at least here an influence of age between the 60-69 years old to 70-79 year old group. What is also interesting to say, and it's more or less similar of what we see in influenza trials and COVID trials, is if you look at a more severe criterion, the estimate is even higher, so 94.1% vaccine efficacy against severe LRTD. If you look at the less severe ALRIs, the point estimates are lower, around 72%. What about safety? So as I said, there's an adjuvant included in the vaccine, so you can expect a more pronounced reactogenicity profile as compared to a non-adjuvanted vaccine. On the other hand, we know in older adults, we have several studies in our site ongoing with young and older adults, and we know that on average the reactogenicity in older adults is less pronounced. You can see 60.19% or 61% had local pain. Majority was grade 1, grade 2, and then the systemic adverse events you can see here on the right part of the slide, with fatigue being most frequently reported, 33.6%. Of course, in placebo group you can also see fatigue. You see very little, or at least not a lot of fever. 2% of the subjects reported fever after vaccination. So this is considered as an acceptable reactogenicity profile. As is also mentioned, the mean duration or the median duration of these symptoms is 1 to 2 days. They resolve spontaneously. Well, good news for this vaccine is the fact that it has been approved for older adults this week, on the 3rd of May to be precise. So the FDA approved the vaccine, which has got the name RSV. And what about Europe? EMA or the CHMP gave a positive advice on the 26th of April, so also very recently, and now this advice has to be well, let's say confirmed by the European Commission, and this is expected in May. This is expected within 2 months. So by the end of June, normally before summer holidays, RSV should be approved in US, which is already the case, and also in Europe. So the Renoir study, there are some similarities, so I will go a little bit quicker on the design. It's very similar, also in various countries, somewhat larger, stable chronic conditions were eligible. What was different, or a little bit different, is the definition or the primary outcome, the primary objective. So also against RSV-associated lower respiratory tract illness with at least 2 symptoms, or at least 3 symptoms, which they considered as a more severe form, and against ALRI as a secondary outcome. So they had a more limited list of possible symptoms, being cough, wheezing, sputum production, dyspnea, and tachypnea, and at least 2 or 3 needed to be present in combination with a positive PCR test. The demographics were also very balanced between study groups and very similar to the previous study I have discussed. With also half of the population, 51% having a high-risk condition, but they included, for example, tobacco use, and 15% with a cardiopulmonary condition. So here are the results for the Renoir study. So the Pfizer vaccine is the efficacy against lower respiratory tract infection with at least 2 symptoms was 66.7. There as well, the lower estimate, or the lower level of the 95 or the 96, sorry, to be precise, confidence interval had to be above 20, so it's also considered as a successful study. If you look at a more severe manifestation, 3 symptoms, well, then the vaccine efficacy is 85.7%, so very similar to what we have discussed before. The cumulative incidence curves and the mean active surveillance was also 7 months. As for the secondary objective, the vaccine efficacy was 62%, also somewhat lower as we have seen for the first one, so a similar pattern, but still very, very good. What about vaccine safety of this vaccine? You can see here on the upper panel, the local symptoms, lower panel, the systemic symptoms. So remember the 60% pain, this is clearly lower. The effect of the adjuvants for this vaccine, only 10% of participants reported local pain at the injection site. And as for the systemic symptoms, most frequently reported were fatigue, headache, muscle pain at somewhat lower frequency. This vaccine is actually also the results of this interim analysis, because as I said, these studies are still ongoing. The results of these interim analysis has also been submitted to FDA. In February, they received a positive advice from the FDA Advisory Committee, and they expect to have a final decision in the course of this month. So very soon we expect this vaccine also to be probably licensed in the US, and then I assume also soon in Europe. The last one, the mRNA vaccine, big study, sponsor is Moderna. 37,000 participants. The definition is quite similar to what we have discussed for the Renoir study. So lower respiratory tract disease with 2 or 3 or more symptoms. Vaccine efficacy against lower respiratory tract disease, 55 cases were seen in the placebo group versus 9 cases in the mRNA group. So that accounts for a vaccine efficacy of 83.7%. For the 2 symptoms, for the 3 symptoms, it's 82.4%. So there's not a lot of difference here for this trial. This is a bit different from what we've shown in the previous study. The safety profile, only very limited data I found in this press release. So looking forward to the full publication, because we know that, well, mRNA vaccines have a certain reactogenicity as well. The fact that only 4% reported a grade 3 symptom was considered as a a positive result or an acceptable reactogenicity profile. So what is ongoing and what about the future, the implementation, because you can have indeed the best vaccines, if they don't get injected into the arm, they're of no use. So what's next? The studies are ongoing. First of all, to assess the need for yearly vaccination, yes or no, because currently the approval from EMA, FDA, is for a seasonal vaccine. Yes, but studies are ongoing. The follow-up of the subjects continues during a second and even a third season to see if the protection is persistent over multiple seasons. And in the GSK trial, for example, which I know best, there is an amendment to the protocol, so a certain part of the population will get a revaccination and see what that effect is, if you really need to repeat that vaccination year after year or not. Of course, it's also important to know if you can safely co-administer it with other vaccines, such as a quadrivalent flu vaccine, COVID vaccine, or pneumococcal vaccine. And, well, focusing now on Europe, we expect for the first RSV vaccine a final EMA approval within 2 months. And it is expected that RSV in particular, and the Pfizer vaccine will probably follow, will be available already by the end of August this year in the pharmacy. I know NITAG, so national recommending bodies, are writing in various countries, are working on recommendations. In Belgium, for example, it's expected, well, to be published soon, to have a recommendation for adults above 60 years and maybe other risk groups. But of course, a recommendation, I don't know for all countries, but at least for Belgium, it does not mean that it's reimbursed, and it does not mean that it's offered to everybody. So that is indeed a concern, especially knowing that these innovative, novel vaccines come at a price and at a cost. On top of that, I would like to add again from a more or less personal perspective, from a Belgian perspective, but happy to share experiences. I know if it's better in other countries, we do not have an immunization program for adults, for older adults, which could include other vaccines such as shingles, pneumococcal, and so on. It's really done on an individual basis, very often not reimbursed, with very low uptake rates, so little or no impact on the epidemiology in this population. And yes, as I said in the beginning, we need more surveillance data for sure to know more about the burden of disease, but also if you implement a vaccine and you want to know the cost effectiveness, you want to know the baseline situation before you implement it, this is very important, and it's good to know that WHO as well as ECDC are really working on that. So to conclude, I think we can say, based on the results I've shared with you today, that RSV in older adults has become a vaccine-preventable disease. There are 3 vaccines in late-stage clinical development or approved, and maybe a 4th one will come soon in the course of the coming months. They're effective, and they have an acceptable safety profile. But, well, now implementation of this vaccine in the vaccination schedule for older adults is key. I think we need to, well, work on lifelong vaccination, and it's not only about protecting young children and babies, especially also in areas of the world with an aging population. Healthy aging and lifelong vaccination as a part of that preventive program is very important. And together with the maternal and the pediatric RSV vaccines, these have the potential to significantly reduce RSV-associated morbidity and mortality. Thank you very much for your attention.